welcome to Nurses Showdown Clinical Knowledge Battleground. All right, this is the first game show for nurses. This is going to be epic. This show is meant to be fun, engaging, entertaining, and I'm your amazing host, Felicia Igbinosa. Woo! Thank you.
Felicia.
I just want to thank you guys for joining me here today, and I have two amazing nurses, one representing the pediatrics department, also maybe representing other departments because she is a well-rounded and seasoned nurse. Then we also have another one representing MedSurg, who is also a seasoned nurse and has been in the ED, done tele, but I'm not going to be the one to introduce y'all, so I'll let you guys do your own introduction. So before we go any further, I'm going to have Frank tell us your name, your background in nursing, and how long you've been a nurse.
My name is Frank, Frank McFawn. My background nursing, you said already. Did most of my time in tele, and then for about 6 years. And we had some once in a lifetime kind of thing happen in COVID, and so was there for a couple more years. Then transitioned to ED for about almost 2 years, and then now my new position in MedSurg this year. I started, so about almost 8 years nurse.
Okay, all right. Perfect. We have Frank here, who is a well-seasoned nurse, and thank you so much, Frank, for joining us today, and welcome to Nurses Showdown. All right, over to you, Tami.
Hi, my name is Tami McCartney, and I currently work in regular pediatrics, the acute pediatric floor at my hospital, and I love every minute of it. My background is 36 going on 37 years now, so I had to write a list. So I started out in labor and delivery, and after a year went to the emergency department, a level 1 trauma center, worked there for 5 years straight, and then went into the PICU at the same hospital and worked simultaneously in the ER and the PICU. I also have experience as a rotor flight nurse, rotor blade, and a clinical instructor for the RN program in our area. And most of my years have been in the pediatric ICU, and I was also a procurement transplant coordinator for One Legacy at one point in there. And that's about it, I hope.
Ooh, wow. Okay.
Wow.
No pressure. No pressure.
I know. Needless to say,
that's amazing.
That is amazing. She has done it all. She's done it all. Oh my gosh. Okay. All right. Well, thank you, Tami, for joining us, and welcome to Nurses Showdown. Now, before we continue, I would like to just put a little disclaimer out there about the show. Again, as I have mentioned in the beginning, that this show is meant to be entertaining, meant to be engaging, and meant to be just strictly fun. So if you're a nurse or nursing student, this is where it's happening. This is where you want to be. Okay, this is where you want to come and get your brain tickled a little bit, get your skills and your knowledge sharpened. And if you're a nursing student, this is where you want to come and learn some real life clinical scenarios we deal with in the real world. All right, so welcome and thank you all for joining us. And please, whatever information you get here on this show, make sure you are following your hospital policy, you're following your doctor's orders for your practice on the floor. Okay, yes, we do give correct information. These questions are based on real life scenarios we deal with. So you just want to use this to supplement what your hospital or your facility policy tells you to do. Okay? All right. Now, let's set some ground rules. Make sure you have a paper and a pen to write, because you'll both be writing your answers down. All right. Okay, so more of the rule. Somewhere in there, if you get a question that is a bit challenging and you don't know how to answer, you get an opportunity to call a friend. Yeah. Okay, so there can only be one winner. Whoever wins, whoever has the most points wins the game, and the other person, whatever is left of your depletion will be added to the winner's money. All right, but the other person gets to go home with a Gemsy Scrubs, and the winner, I know right? And the winner also gets to go home with a Gemsy Scrub. So this makes it a little bit more competitive, right?
Right.
Okay. So speaking of Gemsy Scrubs, Gemsy Enterprises is the owner of Gemsy Scrubs. They design beautiful, amazing, super comfortable scrubs. They have several collections. Some are unisex and some are for females only. But let me tell you, these scrubs are amazing. I'm actually wearing a design from their Demure collection. I wear them to work. I see nurses wear these scrubs to work. They are super comfortable and super fashionable. And there's no way you wear these scrubs to work and not get compliments. There's just no way you don't get compliments. Or somebody asks you, where to get those scrubs from? Give me the link. Okay, so thank you Gemsy, for extending a hand of sponsorship to Nurses Showdown, and we are gladly accepting it. So please go to www.gemcymart.com to order a pair. www.gemcymart.com, kind of like Walmart, but Gemsy Mart, GEMSIMART.com. All right, now let's move on to the show proper. Do you guys have any questions about the rules?
A question. Okay. I have a question. Can we write down parts of the question for ourselves so we can keep track of all the facts?
Well, you would
or not?
Well, that takes me to another part of the rules. You will be asked you will only have 10 seconds to answer each question.
Okay.
And you both will answer each question. Now, I will ask you guys to choose a number between 1 and 10. Whatever number you choose will represent the question you get. But you both will answer the same question, and you both will be asked to show your answers at the same time.
Mm-hmm.
Yeah, and you have 10 seconds.
Okay, that's 10 seconds.
Exactly. Okay, are we ready, nurses?
Yes.
Are we ready to get the show on the road?
Yes.
All right, okay, let's do this. We'll start with Tami. Choose a number between 1 and 10.
And write it down?
You can write whatever number you choose down.
Okay.
Number between 1 and 10.
Can you see it?
No, you can tell me the number.
Oh, 8.
Okay. Tami, 8. Okay, let's pull up. Okay.
Ooh, we're going to get glasses on for this one.
Question number 8. A patient with acute psychosis refuses antipsychotic medication, stating they do not trust the staff. The team is concerned because the patient has been escalating and threatening another patient. What should the nurse do? Here are the answer options. A. Force the medication immediately. B. Assess the patient's decision-making capacity regarding the medication and document findings and follow legal and organizational procedures for involuntary treatment if the patient lacks capacity or poses imminent danger. C. Respect and document the refusal. D. Tell the patient they will be restrained if they refuse. You have 10 seconds.
Who's going? Me. Okay.
No, not yet.
Oh.
I'll let you know when the time's up.
Okay.
Okay. Time's up. Now, I need both of you to show your answers at the same time. Just put your paper up to the screen.
Okay.
B. And Frank, what'd you write?
B as well.
Okay. B. Okay. Tami, why did you choose B?
B, I guess because I wanted to make sure that the assessment was intact. So it does say to assess the patient's decision making regarding the medication. I probably would document after the fact though. But I would follow the policy of my hospital and the policy of a good and prudent nurse, the standards of care in the community. And I would keep patient safety at the top, and other patient safety as well.
Okay.
As the top of my decision.
Very well. Frank, why did you choose B?
First, as Tami said, safety's first, so threaten other patient, threaten other people. Also, since he's in psychosis, you want to make sure he's even able to make that decision. It sounds like this medicine will probably help him, but like everyone says, you have the right to refuse, unless you're being, you're detained if you're 5150 or and such. And then unable to make your decision. In that case, you go to the next, like Mexican, or it's the 5150 is kind of odd, like gray area.
Yeah.
I ask more people. I'd probably ask, the nursing supervisor, and they'll know more about that.
Okay.
Especially for hospital policy, but also always assess. All right.
Okay. Very well, very well. Nursing 101 is assess. Assess, assess, assess. You can never over assess. All right. Here is the answer. Let's see if you both got it wrong. All right. B. Very good, very good. Assess the patient's decision-making capacity regarding the medication, document findings, and follow legal and organizational procedures for involuntary treatment if the patient lacks capacity or poses imminent danger. And here is why we do this. Respect for autonomy requires assessing capacity. If the patient lacks capacity and is a danger to self or others, involuntary treatment may be lawful and necessary following policy. Forcing medication without assessment or coercion is inappropriate. Ignoring the risk endangers safety. So very good, nurses. Very good, very good. Frank, choose a number between 1 and 10, excluding 8.
7.
7. All right. Question 7. Question 7. Here we go. A 62-year-old patient on hemodialysis complains of sudden chest pain and shortness of breath mid-treatment. The blood pump is stopped immediately. What is your priority as a nurse? A. Check for kinks in the bloodline. B. Clamp the venous line and return blood to the patient. C. Administer nitroglycerin. D. Notify the provider immediately. You have 10 seconds. Three, 2, 1. Time's up. Show your answers. What'd you write, Frank?
I put D since we already stopped the pump immediately.
Okay, so D. All right.
Yeah.
How about you, Tami? Show your answer.
D as well. I wouldn't want to give nitro because I might bottom out their blood pressure for no reason.
Okay.
And like Frank said, we already stopped the pump.
Okay.
And I don't want to waste my time checking for kinks, like as my first priority. I would after the fact of notification.
Okay. All right. Very good. Frank, what's your rationale?
Well, we stopped the treatment, which we're assuming that caused the sudden chest pain, or would make it worse if it is a reason why. And then we can get orders quickly and faster when we call the provider immediately for complications.
Okay.
It doesn't look. I don't know with the nitro. It seems like it's probably with hemodialysis, not like a STEMI kind of or chest pain kind of thing from STEMI.
Okay.
Or a PE.
Yeah, or PE. Yeah,
Okay.
shortness of breath.
Is that your final answers, nurses?
Yeah.
Yeah.
Yeah? Okay. All right. Here's the answer reveal. B.
Ooh.
You want to clamp the venous line and return blood back to the patient. And here is why. This presentation suggests an air embolism. The nurse should clamp the venous line, place the patient in left Trendelenburg, and return blood if possible to prevent air entry into circulation.
Ooh.
That makes sense.
Yeah. Sudden chest pain.
I guess we would have to maybe know about dialysis.
Yeah. It's learning opportunities. This is good.
Sure.
It's been a while since I did questions like these. It's awesome.
Yeah.
Good. And now you know, in case you ever decide to become a dialysis nurse, at least you can check that off.
That's for sure.
Off your competency box. Like, okay, got that. All right, Tami, choose a number between 1 and 10. We've done 7 and we've done 8.
How about 1?
Okay. Question 1. All right, question 1. Here we go. A 58-year-old patient in the ICU is 4 hours post-op for an emergency laparotomy for bowel perforation. He is on norepi, that's levo, 0.05 mic per kg per minute. MAP is 58 millimeter mercury. Urine output is 10 mL per hour. And the patient's lactate is rising and it's now at 4.2 millimole per liter. The central venous pressure is low and the surgical drain shows decreased output. What is the most priority? What is the most appropriate immediate action as a primary nurse? Oh, it's giving me B first. B, administer a 30 ml kg crystalloid bolus and reassess fluid responsiveness. C, start a broad spectrum antibiotics only. D, begin dialysis for lactate clearance. I'm not sure why. A, increase the norepinephrine dose immediately. You have 10 seconds. Three, two, one. Time's up. Show your answers. What did you write? B.
B.
Okay.
B, yeah.
What did you have B too?
Yeah.
Okay, Tami, let us know what your rationale is for your answer.
Okay. I want to do fluid. It's it sounds like his tank might be a little bit low. And I don't want to increase the norepi yet because I don't want to clamp him down any more than he may already be. So I want to perfuse his kidneys. And I might be wanting to start antibiotics as well, but fluid bolus first. It's going to take a minute to get the antibiotic from pharmacy. So what I can do first is give a bolus, and I don't believe that we do dialysis for lactate clearance, but I don't know much about dialysis apparently. So B.
Okay, very well, Tami. How about you, Frank? Why B?
Yeah. I was in between B and C, and what got me was like the only part. I'm like, whoa, you should probably already be on antibiotics already, but the only he's just a little soft, right? MAP 58. But the urine output 10. Give him some more fluids might bump him up.
Okay. All right. Very good. And yeah, usually, especially patient that is post-op surgery, usually they put them on antibiotics coming out of the OR anyway. So, okay. All right. Very good. Good rationale. Okay. Let's see if you're both correct. B. Woo! You are both correct. Administer 30 mL per kg crystalloid bolus and reassess for fluid responsiveness. And here is why you do that. This presentation is consistent with ongoing hypovolemia contributing to septic or hypovolemic shock with rising lactate and low urine output. Initial resuscitation requires addressing intravascular volume deficits. An immediate fluid bolus and reassessment of responsiveness are appropriate. Escalating vasopressors without correcting preload may be ineffective. Antibiotics are important but not immediate resuscitation step. And dialysis does not clear the cause of elevated lactate. So, very good, nurses. All right, Frank, a number between 1 and 10.
2.
Number 2. Okay. Number 2. A 45-year-old patient who was extubated in the ICU for respiratory failure develops progressive inspiratory stridor, accessory muscle use, and oxygen saturation falling to 88% on supplemental oxygen. The patient appears anxious and is unable to speak clearly. What is the most appropriate immediate action? Here are your answer options. A. Reassure the patient and observe. B. Administer nebulized epinephrine, provide 100% oxygen, perform jaw thrust, and prepare for possible reintubation. C. Give oral steroids and discharge them from ICU. Kind of like, step down. D. Encourage coughing and deep breathing. You have 10 seconds. Three, 2, 1. Show your answers. B. What'd you write?
B.
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 All right. Frank, why did you choose B?
Stridor epinephrine. That's what goes in my head quickly. And if he failed the extubation, probably gonna reintubate. It'd be kind of mean to discharge him from ICU when he's declining.
You just got a rapid response and give them back their patients.
Yeah, I don't know if you guys ever done this, but like reassure a patient that's sucking air and like very air gasping. It doesn't help at all. Like just deep breaths, and they can't. They would if they could, but yeah, that seems the most appropriate for me. B.
Okay, very good. How about you, Tami?
Well, my priority is airway. So, racemic epi for stridor to get the laryngospasm under control and the inflammation of the airway down immediately. Okay. And at the same time, I'm going to optimize his oxygen by increasing the FiO2 to 100%. And open that airway. Make sure that the position is right by jaw thrust. And prepare for reintubation for sure.
Okay. Very good. Wow, that's detailed, Tami. Okay.
Not as dumb as they look.
All right, so let's see if you're both correct now. B. Very good, nurses. Yes, administer nebulized epinephrine, provide 100% oxygen, perform jaw thrust, and prepare for possible reintubation. And here is why we would do that. Post-extubation stridor with hypoxemia and respiratory distress suggests upper airway obstruction, laryngeal edema, or laryngospasm. Immediate measures include securing oxygenation, nebulized epinephrine to reduce edema, airway maneuvers, which is the jaw thrust, and rapid preparation for reintubation if the obstruction progresses. Observation or oral steroids only are insufficient when the airway is already looking like it's compromised. Very good. Okay. Tami, Number between 1 and 10.
I'm going to go with number 3.
Okay, number 3. Ooh, another dialysis question.
Let's do it.
Okay. A hemodialysis patient reports tingling around the mouth and muscle cramps. What is the likely cause of this? A. Hyperkalemia. B. Hypocalcemia. C. Hypermagnesemia. D. Hypophosphatemia. 10 seconds. Frank, I see that look on your face.
This is gonna be
3, 2, 1. Time's up. Show your answers. What'd you write?
B.
B.
B?
B.
Okay. Are you confident with that B?
No.
I wouldn't put too much money on it, but I'm like, bulimia, maybe.
All right. So, Frank, let us know why you chose B.
Hypo first would be the first thing I would start, and I don't know what phosphatemia would do, but I know calcemia. You know, you tingling. It's either pretty sure it was tingling.
Okay.
Because of the hemodialysis you're taking away, right? So it was B or D, and then I was like, okay, B.
Okay. All right. So you narrowed it down. Okay. Tami, how about you? Why did you choose B?
Because vaguely back in the recesses of my mind, maybe hypocalcemia would cause leg cramps and tingling of it. It's my best guess.
Okay. All right. Well, let's see if you both guessed correctly. Yes, you did.
Yay!
Woo! All right, so let's see why hypocalcemia will cause muscle cramps and tingling around the mouth. Tingling and muscle cramps during dialysis suggest hypocalcemia, often from rapid calcium loss or citrate binding. Calcium levels should be checked and supplemented if needed. All right. See, another one of if you ever decide to become a dialysis nurse, you let them know, hey, I know one or two things about dialysis. Thank you very much.
Thank you for your service. Yeah. You guys want some water? I'll get you.
All right. Frank, a number between 1 and 10.
I think we haven't done 4, have we?
No, we haven't.
Okay, 4 sounds great.
Okay. Okay. All right. You are coordinating discharges for 3 patients. One has home health already arranged. One has transportation already. And the other one has new oxygen needs, but no equipment has been delivered yet. Who should you prioritize for your discharge? A, the patient with home health already arranged. B, the patient with no transportation. Oh, the other one has no transportation. So the patient with no transportation. C, the patient waiting for oxygen equipment to be delivered. D, you prioritize all 3 at the same time. You have 10 seconds. And remember, we have to discharge 20 of them by noon.
Right.
3, 2, 1. Time's up. Show your answers. What'd you write?
C.
C. What'd you write?
So the
A?
question.
Okay.
Wait, you're coordinating discharges for 3 patients. One has home health. One.
Okay, so you chose A.
A.
Okay, and you chose C. All right. So Tami, let us know, why did you choose A?
Well, I chose A because they already are. Everything has been arranged for them, so I'm just going to get them out the door. While at the same time, I'm calling having my discharge planner call the on the oxygen equipment, and then I'm going to call my house supervisor, going to be working on transportation for the other one at the same time that I'm discharging home health, so that the beds won't be, I don't want to waste my time doing the oxygen coordination when I could be sending a patient home first.
Okay, so then that means your answer really is D. You're prioritizing
D.
all
Yeah,
three.
sounds like you're doing
time.
it all at the same.
Yeah,
I'm thinking maybe you should show D now too. I'm like, oh wow.
I guess it is. I'll change it to D.
To D. Okay. All right. So your answer is D. All right. So Frank, why did you choose C?
I chose C because it seemed like we want to start the hard thing first and see if it ball rolls. So the other ones were already rolling, and transportation, unless it's 100 miles away, it's rather easy to get. Or if it's burning, that'd be hard too. But oxygen, I feel like it's been a little bit more difficult to get set up.
Okay.
The hard thing first.
Okay. All right. So here is your answer reveal. C.
Oh.
Woo, Frank! So the patient waiting for oxygen equipment, because yes, you are right, that is the hard thing first. You want to prioritize that and get that ball rolling. All right, so here is the rationale. A patient with a new need for oxygen cannot be safely discharged without the equipment, making them top priority. Okay. Again, airway, breathing, circulation, right? A, B, C, the ones with the need for oxygen comes first.
Well, the thing is that threw me was the new need for oxygen. I mean, if he has a new need for oxygen, maybe he shouldn't be discharged. No, I'm just kidding.
I mean, patients, say, you have a patient who's newly diagnosed with COPD, right? This patient is likely going to go home with oxygen. At least maybe at bare minimum, maybe 2 liters.
Mm-hmm.
Because you can't wait for them to be weaned off of oxygen, having them stay in the hospital and racking up daily bills. You can send them home on 2 liters of oxygen. They can manage that at home.
Right on.
Yeah. All right. Tami, number between 1 and 10.
Oh, number 5.
Number 5. Okay. Right. Here is number 5. A patient with multiple medications and mobility limitations is being discharged home. What is the best action to ensure a smooth transition? Here are your answer options. A. Give them their prescriptions and discharge paperwork. B. Schedule follow-ups. C. Coordinate home health and medication reconciliation before discharge. D. Have them call their primary care physician after leaving. You have 10 seconds. Three, 2, 1. Time's up. Show your answers.
C.
You say C? All over. Same line.
Okay. All right. Tami, why did you choose C?
Well, it sounds like this patient not only has an issue with multiple medications, which we need to clarify if they're still going to be continued or not, or changed before discharge. And that's going to require looking at the medications that he was on before. So it has to be, the med reconciliation has to be referred to. And then the home health person, he'll need follow-up to assess his environment as far as mobility goes. If he has requires assistance, assistant mobility devices or anything like that.
Okay. All right. How about you, Frank? Why'd you choose B? Oh, C.
Yeah. Definitely gotta get his medication in order before discharge. So that was either one or A and C to get him his medication, and then with the mobility, he probably needs home health, but it didn't say in the question. So if he needs home health, you definitely need to coordinate with home health. So C.
Okay. All right. Very well. Let's see if you're both correct. C. Very good. Very good. Coordinate home health and medication reconciliation before discharge. And here's why we will do this. Coordinating home health and verifying medications prevents complications and reduces readmission risk. Good. Okay, Frank, a number between 1 and 10.
Did we do 6 already or
No,
5? Okay.
6.
6.
Okay. Okay. Question 6. A patient returns from a percutaneous coronary intervention, also known as PCI, with a femoral sheath still in place. The nurse notices oozing at the site and a drop in blood pressure from 128/76 to 92/60. What should the nurse do first? What is your appropriate immediate action? A. Reinforce dressing. B. Apply manual pressure above the site and notify the provider. D. Remove the sheet immediately. C. Increase IV fluids only. You have 10 seconds. Three, 2, 1. Time's up. Show your answers. B, okay?
B.
B. Very good. Okay, Frank, let us know why you chose B.
Oh, I had to put pressure on a patient once, and you got to put a lot of pressure, and so I'll never forget that. A lot of pressure, and I'm not a thin man, so I'm like, there's a lot of pressure. And one of the surgeons, I remember because they came by once and they showed us it, and people are only putting a little pressure, and she put her whole body into it. So I'm like, okay, that's how much pressure is supposed to be.
So for how long you have to apply the pressure too? It can be a very long time.
And yeah, you have to call for help, so you can't leave. Yeah, a lot of pressure, and then ask someone to call the doctor.
Okay, very good. How about you, Tami? Why'd you choose B?
Yeah, I too have been in this situation and was astounded at the amount of pressure that needed exerted. But it would make sense to keep this patient from bleeding any more than he already is.
Okay.
Or she.
Okay. Very well, very well. Let's see if you're both correct. B. Very good, very good. You apply manual pressure above the site and notify the doctor. And here is why. The drop in blood pressure and bleeding indicates possible arterial bleed. Manual pressure above the insertion site is critical to control bleeding, while alerting the provider. Removing the sheet could worsen the hemorrhage. All right, very good, very good. Tami, a number between 1 and 10. We only have 2 numbers left.
Okay, number 9.
Okay. Number 9. Okay. A patient is alert but reports palpitations and mild dizziness. Blood pressure is 120/70 and SpO2 is 97% on oxygen. EKG shows a sustained wide complex tachycardia at 170 beats per minute. What is the most appropriate immediate action? A. Immediate unsynchronized defibrillation. B. Attempt rate control with IV amiodarone while preparing for possible synchronized cardioversion. C. Vagal maneuvers. D. Don't treat the heart rate since blood pressure is acceptable. You have 10 seconds. Three, 2, 1. Time's up. Show your answers.
We might be different on this one.
What's that, Tami? B?
C.
C, okay. What'd you choose?
I chose B, but a C made sense too.
Okay, so C.
So C.
C, Tami. Tami, let us know why you chose C.
This is a patient's alert. So least invasive. Try to get him out of that rhythm.
Okay.
And plus I haven't had ACLS for a few years. I'm like, crap.
Okay. All right, so B. Frank, why'd you choose C?
Yeah. Well, C made sense too. I chose B. Possible synchronized cardioversion.
No, you chose B or C?
B.
B.
Yeah, to see if we can cardiovert medically and then possible synchronized since he's alert.
Okay. Okay, so you both chose B.
No, I chose C.
You chose C. Okay.
But then vagal maneuvers help too. I'm like that'd be the easiest, you know?
Okay.
That makes sense.
Okay, so you
like, bear down.
You chose B, Frank, and Tami chose C. Vagal maneuver. Yeah. Okay. All right. Are you ready for the answer reveal?
Oh. Yeah.
Okay.
It's a day.
B.
Oh.
Very good, Frank.
First.
But I would definitely do the vagal maneuvers first. That's the thing. Maybe they said in the question like, "Hey, he already bared down," and try to calm him down a bit.
But it's a wide complex tachy, and it's at 170. So you want to give amio immediately to help with that.
Yeah, if it was a narrow complex, I think that's where the vagal comes in.
Right.
Oh.
Yeah, but you guessed correctly. Good. Attempt rate control with IV amio while preparing for possible synchronized cardioversion. And here is why we will do that. A stable patient with wide complex tachycardia and a pulse should receive antiarrhythmic therapy, amio, and be prepared for synchronized cardioversion if instability develops. Unsynchronized defibrillation is for pulseless ventricular arrhythmias. Vagal maneuvers are ineffective for most VTACs. right? Because it's wide complex, that's VTAC. The narrow one is a sinus tachy. Right. So, and ignoring the rhythm risk rapid deterioration.
ACLS.
ACLS, Tami.
That's what I get for hanging out in peds.
Your patients are much cuter.
Yes.
All right. So the last question, that's Frank. Number 10.
I guess I'll choose 10.
Yeah. Okay, number 10. Early decelerations are noted on the fetal monitor that mirror uterine contractions. And okay, it mirrors uterine contractions and the mother is otherwise stable. What is the appropriate nursing action? This is L&D, baby.
My favorite subject.
Right? A. Initiate immediate cesarean section. Delivery. Cesarean section delivery. B. Recognize early decelerations as benign, head compression, and continue routine monitoring. C. Start IV magnesium sulfate for fetal neuroprotection. D. Administer terbutaline to stop contractions. You have 10 seconds.
Okay.
I'm probably never going to do a immediate cesarean. So, there goes
all right.
A.
3, 2, 1. Time's up. Show your answers.
Oh, gosh.
That was math, huh? Is it B?
Euro B?
Yeah.
Okay. B. Okay. You both chose B.
B because the other answers seem kind of dumb.
Yeah.
Okay. Why did you choose B, Frank?
Well, I'm not very versed in baby L&D, but it kind of makes sense that with contractions, the head may be getting closer to the uterus, maybe causing decels. When I first heard the question, I was like, oh, turn him on the side, right? I don't know which side, maybe left side.
Yeah.
That was my first thing, and then that wasn't in part of the thing, so.
Okay.
Kind of makes sense with the head compressions.
Okay, so it's benign. Okay.
Yeah.
Tami,
how
about
early
you?
decel.
Okay.
Well, early decel, I would put her on her side, on her left side, get her off the inferior vena cava so I can increase perfusion of blood and oxygen to the baby and turn up her oxygen. But benign, I don't know how benign they would be, but the other answers are... anyway,
yeah.
decels.
What's early decels? Like early part. What does that mean? The early. I know decels is like those dips.
I guess we could deliver, too.
Okay, so what's your answer?
What's my answer?
Is it A or B?
Well, they're not benign, so...
Yeah, that you said benign is solid.
And I don't want to start terbutaline and stop her in the middle of freaking delivery. No, I'm going to do a C-section. I'm going to do A.
A, okay. All right, Frank.
I like your reasoning.
So are you
I chose B, but I like your reasoning.
But you're sticking with B.
Yeah, well,
don't listen to me. I'm losing.
I like her reasoning. So I do like the cesarean. And when in doubt, get it out.
Okay.
I don't think that's Save the baby.
Save the baby.
Save the mother
so you're sticking with B though, right, Frank?
Yeah. Well, the head hitting with decels, I guess, but I'll say with B.
Okay.
But A does make sense.
A for Tami.
With her.
B for Frank. All right. Let's see who's correct here. B. Woo!
Oh,
See what happens when you change your answer at the end.
Exactly. You never do that.
All of your people out there that go with your gut, your first answer, and don't lose like me.
Oh no, this is a learning experience. I haven't seen a question like this since 8 years ago.
I know, right? So I'm even surprised to like turn them to the left side. I mean,
it is the left, right?
Yeah, I mean that's amazing that you even remember that.
Yeah.
All right. So recognize early D cells as benign head compression and continue routine monitoring. So let's see why. Early decelerations that mirror contractions are usually due to fetal head compression and are generally benign. No immediate intervention is necessary other than continued monitoring and routine care unless other concerning signs develop. Okay, that means the baby's head is, it's in the birth canal. Yeah, compression is expected.
With every single contraction, that makes sense.
Yeah.
As long as it goes back up.
Right, exactly. Okay, so this concludes this episode. I'm super excited, and there's a clear winner in this one, so we won't have to go into a tiebreaker question.
Can we do it instead? This is my.
You want to do the question? You want to do the question?
I'm still gonna lose, and you're still gonna win. Where's your?
Yeah, but I don't have any. This is my first time ever doing questions like this for 8 years. It's kind of fun.
You're having a good time with the questions.
Yeah.
Okay. Here is our tiebreaker question, which is not a tiebreaker. All right. A patient lacks decision-making capacity, and the family is split between continuing aggressive measures and focusing on comfort-focused care. The medical team believes the patient's prior documented wishes favored comfort. What is the most appropriate immediate action? A. Unilaterally withdraw life-sustaining treatment. B. Facilitate a structured family meeting, including palliative care ethics, and the primary team to review the patient's wishes and arrive at a shared plan. C. Continue current care. D. Discharge the patient home for family to deal with and figure it out. 10 seconds.
That's cruel. My obvious answer for me is going to be B.
B?
Okay.
Sometimes it's always the long answers that's always the right answer, right?
Well, you don't always want to count on that.
Yeah, plus there's a lot of B answers in this test, I noticed.
Yeah.
Oh, yeah.
All right. So time's up. You both chose B. Very good, nurses. Yes, you want to facilitate a structured family meeting so everyone has an input, everyone can come up with a plan, everyone is happy with, right? At the end of the day, it also is in the best interest of the patient.
Yes. And you know what I was thinking? Oh, go ahead.
Oh, no, I mean, this last question is pretty much for fun. And it says, when families disagree, the nurse should advocate for a mediated, multidisciplinary family meeting that includes palliative care and ethics resources to align the plan with the patient's documented preference and clinical realities. Unilaterally, making a decision to withdraw care or ignoring conflict is inappropriate. And discharging the patient from the ICU or from wherever floor they are on for the family to go figure it out is just, like you said, cruel.
Yeah, well, again, family and patient-centered care, family-centered care as a priority.
Yeah.
And that's what we're all evolving to and should be focused on. I would just remember when I did One Legacy,
Mm.
and the families were really torn, between their decision. I know this is not a One Legacy case, but what to do. We would gently collaborate with the family and ask them if they ever, had a conversation with the patient about their wishes, ahead of time.
Mm-hmm.
Most people had not.
Yeah.
But the people that did go back to the patient's decision were usually able to come up with a decision.
Yeah. Very good.
Patient's wishes,
Yeah.
and that helped the family make their decision. But it sounds like a meeting was required for sure.
Yeah.
Mm-hmm.
I mean, at the end stage of life, these kind of decisions are usually very difficult to make.
Yeah, it's kind to be clear.
Yeah.
For if you're the patient, be clear to your family.
Yeah.
I think even I don't have one of those yet, but like a POLST.
Yeah.
And but I tell my wife all the time what I want, but have it legal.
Yeah.
Kind of thing.
But then even sometimes though, it doesn't really matter how clear you are to your family. When it actually comes down to it, it doesn't make it any easier. It's still very, very difficult because this is your loved ones. And yes, you know what they want, but you're in denial. You're still very much attached. You don't want to let them go. So it's still you know what the right decision is to make, but making that decision becomes very tough.
Yeah, there definitely needs, I think, to be like a commercial or something should be made on, have that conversation with your family because there's just a lot of mayhem that goes on.
Accidents and
on that last day. Next of kin will always have the decision. Even they can go against the patient's wishes, which is bizarre. But if you don't have, if it comes down to you not having written it down, on your POLST refrigerator.
Yeah, and another heartbreaking scenario we deal with more often than not is when you have patients who don't have any family representation. And they are at the end stage of life. They're dealing with critical issues, but then you have the hospital ethics committee having to make decisions, yes, in the best interest of the patient, but may not necessarily be what the patient wants. But because there is no written post, there is no family representation to let us know this is what the patient would want. We are making these decisions that are in the best interest of the patient, but maybe against what the patient wants. But then the patient is not in a position to let us know what actually is they want.
Yeah, because death happens briskly.
Yeah.
Even when you're expecting it.
Yeah.
It's like, whoa, like I wasn't expecting that.
Yeah.
Today, right now, So it's definitely good to have that in place ahead of time, but I think that us as Americans really fail.
Yeah.
We don't prepare for end of life. We don't prepare very well.
Right. And at least have someone within your circle. It could be a neighbor, a friend. And I've actually run into a situation where a friend was the DPOA of a patient, but they refuse to make the decision. They know what the patient wants, but they're like, no, I don't want to be the one to pull the plug. I don't want to be the one to make because it's tough. They don't want to bear that responsibility of making a decision as big as that. So we as healthcare workers, we have a lot of responsibilities and we carry a lot of burdens of people we don't even know, but we're having to make decisions for them, life and death decisions for them.
Yeah. So thus the ethics committee.
Yeah.
I wonder, I've never seen the ethics committee. Do they probably err on the side of prolonging life versus quality of life, right? That's what I would assume. You can't say you don't.
Yes.
You didn't do everything.
They will do it, but before an ethics committee come together though to make these kind of medical decisions, you have social workers and case management, like they are all up in it, trying to find family, trying to find friends, somebody who knows this patient and may want to take up that responsibility to make. But then if you're in a situation where you can't find anybody, yes, they come together and they end up, making decisions, sometimes to prolong life, depending on how critical or not the patient is. But we know the prognosis is really bad, so they do everything they can to make sure that, okay, when they do decide to arrive at a decision where the only option is to terminate, let me not say terminate life, is to put the patient on comfort measures, then you've done everything. You've done everything possible to treat, and it's just not going to work. It's just not working. Yeah. So yeah, wow, this is a good discussion. Oh my goodness.
Oh, I like it. Yeah.
I love it. This is good because it's like I don't know. We should do this like all the time.
Right. Well, more episodes coming up. Oh my gosh.
Fantastic.
Yes, I love this. I love how engaged this is, and this is the goal of this show. The goal is to make it engaging, thought-provoking, and induce some critical thinking. And I thank you both for joining me here today to accomplish this. And this concludes the end of the show. Ran a bit longer than I expected, but for good reasons. For really good reasons. This is really educational. So yes, Frank is a clear winner of this show.
Shake my hand.
Right? I wish I had some dollars and just make it rain, let it rain.
I think Frank decided before that he was going to answer B for every single.
I see that everything was B. There's like a couple B's. There's one D and mostly B's.
Yeah. All right, thank you guys again for showing up, and I will be sending you an email so you provide me with your Zelle numbers. So that means whatever is left over of Tammy's money is added to Frank's
for next time.
Yeah, so you're gonna have to come back, Tammy. Let's do this again.
A comeback.
Yes, everyone loves a comeback.
Good.
Does Frank get money, real money now?
Oh yeah. Yes, this is real money.
I thought it was Monopoly.
No, it's real money.
Frank, you can take your kids.
Yes.
We're going to Chuck E. Cheese where Dad can sit down.
Oh my gosh, but I'm the one that needs the money, Frank. I was scheduled Thursday, Friday, and
Saturday. I'm sorry. Some people, they work through the Sunday, Monday, Tuesday.
Yeah.
And then they're like, oh, it's just a regular week.
Yeah.
Do the clinical managers strike, or is that still? Oh no, that's part of management.
Yeah.
Okay, got it.
All right. So you'll be receiving your winnings, and Tammy, you let me know what size of scrubs you want.
Not me. I'm not a winner.
Oh no, you still get a Jensen scrub. No. Oh yeah, everyone is a winner. Absolutely. Frank gets a scrub, and you also get a scrub.
Fantastic. Yeah. Do you have all black? That's my go-to.
Yeah, me too, buddy.
All right, I will be sending you your winnings, and you let me know what size you are. Once you get the email, respond back to the email with your size and your Zelle information, and you'll be receiving.
Thank you so much. Thank you so much, Felicia. This was fun. Thank you, Tammy. It's great to talk. I don't know if I've given you a report or not from ER to peds.
No.
Are you night shift or day shift?
Night shift. You probably have.
For sure we have. Yeah.
You know what? As long as you knew your
it
was a good conversation.
Well, I'm glad you don't remember me then, because I did know the patient. You're like, yes, Nurse Frank.
For me though.
No. Well, No, I mean, everyone's been nice.
That's
It's
cool.
a learning experience every time I give reports to Pete's. I'm like,
Right.
oh, really? This
is
is what you want to know.
Okay, cool.
All right,
All right,
guys.
y'all.
Thank you so
Thank
much.
you.
And
Okay.
have a fabulous day.
Will do.
Okay.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Bye.